Hello everyone, I am Dr. Devanshu Sachdeva, Junior Resident from Kalinga Institute of Medical Sciences, Bhubaneswar, Odisha. I am going to present a paper on diffuse peritoneal disease, a pictorial review. Coming to the aims and objectives, it is done to provide an image-based review of various diffusely involving peritoneal pathologies and to highlight the characteristic imaging finding and discuss the various differentials. Coming to the introduction, the peritoneum is a serous membrane of mesothelial cells that lines the inner surface of the abdominal cavity and involves many of the major solid and hollow organs. This can be the site of various primary, second neoplastic, and non-neoplastic pathological process. Multi-detector CT is the most commonly used technique for the detection and evaluation of various peritoneal pathologies and to look for its extent. Coming to the etiology, it can be neoplastic, infectious, or miscellaneous. Under neoplastic, primary will be peritoneal mesothelioma or serous carcinoma, whereas in secondary it can be carcinomatosis from ovary, stomach, colon, or pancreas. Coming to the infectious, it can either be tuberculous peritonitis or pyogenic peritonitis. Coming to miscellaneous, it can be pseudomyxoma peritonei or sclerosing encapsulating peritonitis. Coming to the imaging modalities, on ultrasound, what features can we see are the omental caking, peritoneal nodules, and ascites, which can either be free or loculated. CT being the modality of choice, we can see nodule, plaques, omental caking, ascites, which can be complex or separated, scalloping of liver and spleen, and calcifications. Whereas on MRI, it is for better contrast for ascites and mucin, and diffusion weighted imaging detects small deposits. With the clinical feature, what the patient presents usually with are abdominal distension, pain and weight loss, ascites, and they are mostly often non-specific, and thus imaging is very crucial for the diagnosis. Coming to the first case, if it's of peritoneal carcinomatosis, it is a case 75-year-old female with bilateral malignant ovarian masses. On CT scan, we can see extensive nodular soft tissue infiltration of the omentum, which is known as the omental caking. An irregular nodular peritoneal thickening is there. Coming to the second case, which is peritoneal tuberculosis, a 50-year-old female with complaints of abdominal distension and low-grade fever for 2 months. We can see thickened enhancing nodular omentum and thickened nodular peritoneum. Coming to the next case, which is pseudomyxoma peritonei. Case 3, a 68-year-old male with complaints of abdominal distension, anorexia, generalized weakness for 3 months. We can see omental caking with scattered curvilinear calcification and scalloping of the hepatic margins is there. Next case is the diffuse peritoneal hydrosis. It is a 11-year-old female child with gradual distension of abdomen for 2 years. We can see multiple variable sized cysts mostly diffusely scattered in the peritoneal and the retroperitoneal cavity. Next case is the diffuse peritoneal lipomatosis. A 42-year-old male complains of altered bowel habit, loss of weight, and gradual distension of abdomen for 2 years. In images, we can see diffuse fat deposition in the peritoneal cavity and the intestinal submucosa. Case 6 is the diffuse peritoneal leiomyomatosis. A 45-year-old female post non-descent vaginal hysterectomy with complaints of swelling of lower abdomen and pain abdomen for 6 months. In images, we can see multiple well-defined enhancing solid nodules noted in the peritoneal cavity, and in this one we can see a large well-defined enhancing lesion noted in the pelvis. Coming to the discussion, peritoneal carcinomatosis is the most common cause of neoplastic diffuse peritoneal disease, whereas peritoneal tuberculosis happens to be the most common non-neoplastic diffuse peritoneal disease. Evaluation for key imaging features like presence of local invasion, extent of ascites, type of peritoneal thickening, involvement of omentum, presence and character of lymphadenopathy, and presence or absence of cystic, calcific, or fat density may allow the radiologist to infer more specific diagnosis and guide the clinical management. These are my references. Thank you.